What's going on, besties? In this video, we're going to be talking about diagnostic, complication, and treatment of hypertension. I've already filmed the video about the pathophysiology and what you want to look for, so make sure you go check that out first before you watch this video. Let's get started. So what is the initial assessment that we're going to want to do when we have someone with hypertension? Well, we want to get a history of the elevated blood pressure maybe happening with themselves or even in their family. So either it's going to be a personal history or a family history of elevated blood pressure. We also want to know about cholesterol, right? Because cholesterol can ultimately lead to an increase in that plaque happening within our arteries. So if we're having a resistance happening within our arteries, like we talked about before, we're going to have a constriction of that blood flow, ultimately leading to an increase in blood pressure. Do they have any medical history of cardiac, kidney disease, as well as endocrine disorders? A lot of those things can lead to a potential cause of blood pressure. We also want to see what kind of medications they're on. Certain medications can ultimately lead to those higher numbers. So NSAIDs, birth control pills, especially those that have estrogen, steroids, as well as decongestants all play a pivotal role when it comes to our hypertension patients. And then lastly, we have blood pressure assessment. We want to be checking those blood pressures constantly. We want to be following the American Heart Association's guide to what constitutes blood pressure. And we want to make sure that we're treating them appropriately based on the initial assessment, their history, as well as the numbers that we're seeing on our patient. So what kind of signs and symptoms are we going to see? Well, when it comes to hypertension, it's often termed the silent killer. Typically, you're not going to see symptoms until they have reached a severe or even life-threatening stage of hypertension. The most that you may see in the initial stages is usually like flushing of the face, because hypertension can lead to blood vessels trying to dilate under the skin, particularly when it comes to the face, to allow more blood volume to get through. This response is typically a result of that regulatory mechanism attempting to decrease the pressure by dilating blood vessels. There is a medical explanation for each symptom, specifically when it comes to these things. So headache, right? Headache in most cases when we have severe hypertension, we're going to have that excessive pressure in the blood vessels of our brain. They're going to constrict, they're going to try to rapidly dilate, leading to what is known as hypertensive headache. So these headaches are often felt in the mornings, particularly, and are located usually within the back of the head is where it's felt the most. Next, we have shortness of breath. So high blood pressure can put a strain on the heart, potentially leading to heart failure. So we never want to see that. When it comes to heart failure, the heart is going to be less effective when it comes to pumping out blood. It's going to lead to a buildup of that blood in the lungs, ultimately causing potentially pulmonary edema, which is going to lead to that shortness of breath. So we really want to be sure, looking at those lungs, what's happening in there, because if we're starting to see an accumulation of fluid, we're probably heading down the wrong path when it comes to pulmonary edema. Next, we have nosebleeds, right? So although it is less common, severe hypertension may lead to an increase in pressures, particularly with these smaller blood vessels that can be found within our nose. If those blood vessels become very pressurized and they start to constrict and dilate, like the body would typically have them do, you're going to see a lot of ruptures as well as bleeding, leading to those nosebleeds. Next, we have dizziness. So dizziness, when it comes to elevated blood pressure, can affect the balance organs that we have within our inner ears. So that's going to lead to the sensation of dizziness, lightheadedness, just kind of not feeling well. When it comes to that, we're going to see with hypertension, it affects cerebral circulation. So that cerebral circulation, that can also lead to those symptoms of dizziness and that feeling of lightheadedness. And then lastly, we have chest pain. So this is kind of like the obvious one, right? So those higher blood pressures, it's going to cause the heart to have to work harder than normal because it's trying to get that oxygen-rich blood out to all of our body's tissues and organs. This is going to lead to that chest pain and that discomfort. Sometimes we call that angina. So what lab diagnostic findings are we going to see when it comes to the progression of hypertension from its initial to more severe stages? So starting with our blood urea nitrogen that we have right here, a typically normal value, this is going to be very dependent on your institution as well as your nursing schools of what they find normal, but typically based on literature, it's between 8 and 20. So when we're thinking of hypertension, we're going to start to see elevated BUN numbers because it is going to affect our kidneys. Same thing with serum creatinine. With serum creatinine, we're usually looking at 0.6 to 1.2 with men, 0.5 to 1.1 with women. So generally, you're looking somewhere between 0.5 and 1.2 when it comes to serum creatinine. So hypertension is going to damage the blood vessels, particularly in the kidney, impairing the filtration from actually occurring. This is typically known as hypertensive nephropathy. Damaged kidneys cannot effectively filter waste. It's going to lead to an accumulation of substances, which we're going to see with elevated BUN and creatinine levels. Next, we have total cholesterol. So typically with total cholesterol, we want to see numbers less than 200 when we're looking at our patients. Same thing with triglycerides. It's kind of within the same wheelhouse. We want to see numbers less than 150. So it's really going to vary when it comes to these numbers with hypertension, but usually you're going to see them be a little elevated. As part of the metabolic disorders that we see with a lot of our patients, high cholesterol, high triglycerides, you're going to see symptoms like metabolic syndrome when we're starting to see these elevated numbers. So high blood pressure can contribute to the development of arterial sclerosis, like we talked about before. That's that condition where we have fatty deposits building up within the walls of our arteries. So that buildup is particularly composed, you guess it, cholesterol and triglycerides. So as the body attempts to repair damage, cholesterol is often deposited into those arterial walls, exacerbating the problem even further. So elevated cholesterol, triglycerides can narrow and harden those arteries, increasing the risk for coronary artery disease, as well as stroke, and worsening our hypertension. So we really want to, when we see these kind of patients with these high numbers, we really want to help them make dietary-like changes in order to bring a lot of this down. And then lastly, we have ECG, our electrocardiogram. So typically we have a normal PQRST. That is what we see as a patient with a normal heart rate with no signs of heart damage. However, when we're looking at an ECG and we're starting to see hypertension changes to the heart, we're going to start to see left ventricular hypertrophy. So left ventricular hypertrophy, you can also see arrhythmias as well as ischemic changes. So think about it. Our left ventricle is what pushes our blood out to our body. So if our body has all of this peripheral vascular resistance, meaning the narrowing, the constriction of our blood vessels, that pressure within that left ventricle is going to keep trying to push that blood out against that resistance. Over time, the heart is going to have to work harder and harder, making that muscle get bigger and bigger. And that's when we start to see that left ventricular hypertrophy take place because of that consistent progression of hypertension. Now, if somebody had a little bit of hypertension and then made dietary changes over time to get rid of it, and it was more of an acute hypertension, then they're most likely going to be fine. But for those individuals who don't have signs or symptoms, remember, it's the silent killer. So for those who don't have signs and symptoms and don't check their blood pressure regularly, if they're constantly having all of that peripheral resistance and that left ventricle is having to work against all of that resistance, getting blood out from the aorta into the body, then you're going to start to see that elevation, that thickening of the left ventricular wall, leading to hypertrophy. So how are we going to treat this? Well, when we're discussing treatments, it's essential to emphasize lifestyle changes. That's huge. It's a fundamental aspect when it comes to managing elevated blood pressures. The impact of lifestyle modification on blood pressure is well supported and well documented by evidence, particularly when it comes to dietary changes. So adopting a diet that is low in sodium is crucial. And this is where the importance of DASH diets come in. DASH stands for dietary approaches to stop hypertension. These diets are going to ultimately be rich in things like nuts, whole grains, fruits, vegetables. It's highly recommended, especially for reducing high blood pressures. And it's also going to be recommended that you limit the sodium intake when it comes to these particular diets. Additionally, we're going to look at regular exercise and stress reduction techniques such as biofeedback, relaxation, as well as meditation can play a significant role when it comes to managing our blood pressure. These lifestyle changes also may include medications. So a lot of individuals are going to be on medications to help control hypertension if they were unable to control it with lifestyle modifications of their own. So a lot of individuals are going to be tested on different medications when it comes to high blood pressure to see which ones work and which ones don't work. For example, my father has hypertension. He's been on several medications. And over time, they've had to make adjustments to dosaging, adjustments to the type of medication. There was a period of time he was on an ACE inhibitor, which caused him to have a really bad cough, so they switched him to an ARB. When we get into our pharmacology series, we'll get way further into depth about why that happens. Depending on what's going on, it really is going to be a balancing act of finding what doesn't bottom a patient out, meaning dropping their blood pressure way too low, but also maintains them within a healthy level. So the decision of which blood pressure medication to use is going to be based on two different things. They're going to base it on the diagnosis, what's happening with our patient. Do they have primary? Do they have secondary? What's happening underneath? What's the underlying cause? And they're also going to be looking at comorbidities. What's present during the time that the patient has hypertension? If I give them this medication, is it going to interact with another medication that they have, potentially exacerbating it and making it worse? So when we're talking about medications, we're talking about four major types of blood pressure medications. They're called our A, B, C, and D blood pressure medications. A stands for ACE inhibitors and ARBs. Our B stands for beta blockers. C stands for our calcium channel blockers. And D stands for diuretics. I know that there's some additional medications such as like alpha blockers, nitrates, vasodilators, and alpha-2 agonists. They also help treat hypertension, but these are going to be the main ones that you usually see a lot when it comes to medication management with hypertension at home and not necessarily in the hospital setting. Our first one is ACE inhibitors. These are really beneficial when it comes to certain medical conditions. For instance, in diabetes, ACE inhibitors are known to provide kidney protection, which is huge because that risk of kidney problems when it comes to diabetes is major, right? We talked about that in our previous video. In the context of congestive heart failure, these medications can actually improve the heart's ejection fraction, essentially aiding the heart in pumping more blood efficiently. So those are also going to be pretty big. That improvement of that cardiac function is going to be significant when it comes to patient outcomes. Additionally to ACE inhibitors, they've also been shown to increase survival rates when it comes to post-myocardial infarction, post-MIs. That's just a fancy way of saying heart attack. So we really see a lot of ACE inhibitors being used pretty consistently when it comes to the medical setting because they have a lot of really good patient outcomes. Turning our attention to more beta blockers, these medications are particularly beneficial when it comes for patients with congestive heart failure. So again, we can use ACE inhibitors, but beta blockers are really good with congestive heart failure as they're shown to improve survival rates. So they're also valuable when it comes to that post-myocardial infarction MI as well for the same exact reason. So if they have CHF or if they have a post-MI, really we're looking at ACE or beta blockers depending on what's happening underneath. So in the context of managing congestive heart failure, it's important to be aware that there are specific beta blockers that have been proven to be more effective than other ones. So carvedilol and metoprolol are the two key beta blockers that you're going to see a lot prioritized when it comes to CHF patients. When it comes to post-myocardial infarction care, the choice of beta blockers are more varied depending on what's going on. However, carvedilol and metoprolol are usually generally the medications that you'll see. Beta blockers are also known to be effective with our younger patients who are dealing with hypertension. Clinical observations suggest that they tend to work well in our young Caucasian individuals, showing greater efficiency in that demographic. Regarding calcium channel blockers, it's important to note that they haven't really demonstrated a clear benefit on improving survival rates for patients. Therefore, they're not typically used in the primary aim of enhancing survival rates when it comes to various conditions. However, the one good thing about calcium channel blockers is that it is really good for a certain patient population. They have shown effectiveness when it comes to our African American patients or in the elderly, making them a viable option for hypertension management in these particular groups. Similarly, when it comes to our diuretics, they have also not really been shown to have substantial evidence of improving survival in specific conditions, but they're still valuable in certain demographics. So again, our patients that are African American individuals and also our older patients usually benefit from some kind of diuretic. While calcium channel blockers and diuretics may not be the primary choice for improving survival rates, they still are important for managing hypertension in these particular populations. Now let's shift to what we would be looking at when it comes to potential side effects of these medications, as this can be very crucial to be aware of in order to prevent any kind of major adverse event from taking place. So one of the most serious side effects that we see with both ACE inhibitors and ARBs is angioedema, which involves that swelling of the tongue as well as our neck. These conditions can be quite severe, so it's essential that the patients are informed about the risk and that they understand that they need to seek immediate medical attention if they experience any of these symptoms. Another common side effect that's extremely common actually when it comes to ACE inhibitors is a persistent cough. Patients start to develop this cough while they're on ACE inhibitors and they can't handle it when it comes to, cough drops or things like that, and it's just becoming persistently aggressive. A lot of times we start to see patients come into the setting when they say, hey, I'm coughing all night long and I'm not getting any sleep. That is very common with ACE inhibitors. So usually what the provider will do will switch them to an ARB because they don't have that side effect. It's much less common in ARBs than it is in ACE inhibitors. Among the more frequent side effects when it comes to ACE inhibitors, you can also see hyperkalemia, which is an increase in our potassium. You may even see hyponatremia, which is a decrease in sodium. ACE inhibitors can also affect creatinine levels, especially in patients with renal artery stenosis. ACE inhibitors are often used as kidney-related issues to prevent protein in the urine, especially in our diabetic patient. If our patient has some kind of kidney problem, you may see ACE inhibitors used quite a bit because it does help in those particular populations. While the medications are beneficial for protecting the kidneys in certain conditions, they can paradoxically exacerbate renal problems as well. So there really is a fine balance between kidney problems when it comes to ACE inhibitors. So they really are monitored quite a lot before somebody is just let out on their own and say, hey, take this ACE. They come back quite a bit for patient testing to make sure that the kidneys are working effectively when it comes to ACE inhibitors. So moving on to beta blockers, it's well known that they can decrease heart rate. It's the primary effect of what it does. It also helps lower the blood pressure. So if you have a patient that says my heart rate's low, it's not really so much as a symptom as it's expected. When you're on a beta blocker, your heart rate is going to decrease. There's also a potential increase in lipid as well as cholesterol levels from taking place. Beta blockers can alter lipid metabolism. So that's going to lead to an increased level in triglycerides and in some cases decreased levels of HDL cholesterol, which is the good cholesterol that we want to have. We may also see a potential exacerbation of depressive symptoms. While the connection between beta blockers and depression isn't really fully understood, it is considered essential to make sure that the patient doesn't usually have a history of depression because it can actually exacerbate that symptom. Patients with respiratory conditions like asthma or chronic obstructive pulmonary disease known as COPD need to be carefully monitored when prescribed beta blockers because these medications can actually lead to bronchospasms, making the asthma worse, or COPD symptoms even worse due to the effect of beta receptors that are found within our lungs. So they're highly monitored if they are put on a beta blocker with asthma and COPD. And then lastly, we can see an increase in potassium levels. The potential for hyperkalemia needs to be balanced against the actual benefits of a beta blocker, particularly in patients at risk for electrolyte imbalances. Sometimes we have to kind of say, hey, it's going to increase your potassium, but it's going to help with this. So you have to kind of find that balance between the two when it comes to a lot of these symptoms. Next, we have calcium channel blockers. So depending on what calcium channel blocker that they are prescribed, we're going to see different kinds of symptoms. So with our DPH calcium channel blockers, these are the ones that typically end in our PINES, P-I-N-E-S. So our nifedipine or amlodipines, those type of medications. And the key point of these PINES is that they're primarily used for peripheral vasodilation. So this means that they're going to act on blood vessels, causing them to become much more wide, ultimately lowering the blood pressure as well as the heart rate for that matter. In contrast, if we have non-DPH medications, we're looking at the MILs, the MILs, the ZIMs, they're going to work a little bit differently. They're known for the reduction in inotropy. So this essentially means they're going to reduce the contractility of the heart, leading to a decrease in the heart rate. So there's an interesting exception worth noting when it comes to amlodipine. So amlodipine tends to not increase the heart rate as much. In fact, it can cause the heart rate to actually decrease. So the characteristic makes it particularly beneficial in the management of ischemic heart disease because we don't want that heart working any harder than it already has to. But in general, calcium channel blockers, you may see things like edema in the lower legs, constipation in some cases can occur. There may even be an exacerbation of heart failure that takes place. And that's just due to their negative inotropic effects, particularly significant with our non-DPH medications. And then lastly, we have diuretics. It's easier to break these down into two types of categories. You have your thiazide diuretics and you have your loop diuretics, such as like Lasix and furosemide. So the differences between these two are significant. Each is having their own set of side effects. So like hydrochlorothiazides or thiazide medications, they work on the distal convoluted tubule and the ascending limb of the loop of Henle in our kidneys, while Lasix acts on particularly just the loop of Henle. So starting with hydrochlorothiazide, there are 4 key things that are going to increase in the body. Firstly, you're going to have a rise in calcium levels, which in contrast to Lasix, known to decrease calcium levels. Secondly, it's going to increase uric acid levels, potentially worsening conditions such as gout. As we know, gout is when those little crystals get into our joints and it causes a lot of pain. Thirdly, hydrochlorothiazide can elevate lipid levels. And lastly, it can increase blood glucose levels, a concern for patients that have diabetes, right? So we want to be careful with giving those medications to those patient populations. While both hydrochlorothiazide and Lasix generally decrease potassium levels and increase creatinine levels, potentially resulting in renal failure, they can also lower sodium concentrations, sometimes causing hypotonic hyponatremia. So you have to be really careful with those particular medications with that as well. So these differences sometimes underline the importance of understanding those specific actions and those side effects that we can potentially see with each type of diuretic, especially in patients with conditions like gout, diabetes, and those at risk for renal impairment. This is the end of the medications that I'll be covering when it comes to hypertension, but just know that there are additional ones, but these are the main ones that you're going to need to know for your nursing school tests. I hope that this information was helpful in understanding how we diagnose and treat hypertension. If you have any additional questions, make sure that you leave them down below. I love answering your questions. Head over to nursechungstore.com where there's a ton of additional resources that are available to you to help you pass those exams. And as always, I'll catch you in the next video. Bye!